All right, let's talk about chronic kidney disease. It's a diagnosis that can feel, pretty overwhelming, not just for patients, but for us clinicians too. But what if we could break down all those complex guidelines into a really clear, actionable playbook? Well, that's exactly what we're going to do today. We're going to focus on the key strategies to slow this disease way down, and maybe most importantly, protect the heart. So let's kick things off with a fact that might actually surprise you. We spend a ton of time tracking GFR, worrying about end-stage kidney disease, but here's the thing. The vast majority of people living with CKD will never, ever end up on dialysis. Okay, so if dialysis isn't the biggest boogeyman for most of our patients, then what is? What is the real enemy that we are truly up against when we manage this condition? And the answer couldn't be clearer. It's cardiovascular disease. Having CKD just dramatically cranks up the risk for things like heart attacks and strokes. So what does that mean for us? It means our entire management strategy from day one has to be centered on the heart. You see, this one fact changes everything. We're not just chasing lab values on a screen. The real goal here is keeping our patients alive and well, and that means putting a huge focus on protecting their cardiovascular system. This triangle right here, this is the perfect way to frame our whole approach. We've got three main objectives. 1, slow down the actual damage to the kidneys. 2, manage all the complications that pop up. And 3, sitting at the top, reduce that cardiovascular risk. That's the whole game.
So here's how we're going to break this down. We'll walk through the three main pillars of treatment. That's pressure control, some game-changing new therapies, and managing complications. And then we'll see how it all sits on that crucial foundation of diet. Our first pillar is all about hemodynamics. It's pressure. Honestly, controlling blood pressure is one of the single most effective things we can do to protect both the kidneys and the heart. Now, our BP targets aren't a one-size-fits-all deal. The big dividing line here is albuminuria, protein in the urine. If your patient has it, we get much more aggressive. We're aiming for a blood pressure under 130/80. If they don't, the target's a little looser.
So where do we start? What's our first-line therapy? Well, for any patient with albuminuria, ACE inhibitors or ARBs are absolutely essential. These are our go-to drugs, and for good reason. They hit both blood pressure and the protein in the urine.
So how do they work? It's actually pretty elegant. Think of the glomerulus, the kidney's filter. You have a blood vessel coming in, the afferent, and one going out, the efferent. ACE inhibitors and ARBs basically relax and open up that outgoing vessel. This lowers the pressure inside the filter, which means less strain and less protein leaking out. Okay, here are the high-yield pearls you have to know. These drugs reduce proteinuria and they slow down the disease. Now, you should expect to see a small initial rise in creatinine. We call it the bump, and a rise of up to 30% is okay. It shows the drug is working. Don't stop it. Just make sure you're keeping an eye on their potassium level.
All right, let's move on to our second pillar. For a long time, ACE inhibitors were pretty much our main tool. But recently, a whole new class of medication has completely revolutionized how we treat CKD.
And I'm talking about SGLT2 inhibitors. Now, these started out as diabetes drugs, but they turned out to be so incredibly protective for the heart and the kidneys that they've become an absolute cornerstone of modern CKD management.
So who should be on these? Pretty much anyone with CKD who also has either albuminuria or heart failure. And here is the really critical part. They work whether the patient has diabetes or not. This is a total game changer.
So what's the mechanism? It's fascinating. They block a transporter in the proximal tubule of the kidney, which makes you excrete more sugar and salt into your urine. This natriuresis does a couple things. It helps with fluid balance, and it also triggers this internal feedback loop that ultimately lowers the pressure inside the glomerulus, protecting it from long-term damage. And look, the evidence for this is absolutely rock solid. Huge, landmark trials like Dapagliflozin and Empagliflozin have shown, without a doubt, that these drugs significantly slow down CKD progression and slash the risk of cardiovascular events.
That brings us to our third pillar, managing complications. Because as the kidneys start to fail, it has a domino effect on other body systems. And taking care of these issues is just crucial for our patients' quality of life and, frankly, for their survival.
Let's just quickly run through the big ones. First, you get anemia, right? That's because the kidneys stop making enough EPO, the hormone that tells your bone marrow to make red blood cells. Next, you have mineral and bone disorder. This is a messy cascade of high phosphate, low active vitamin D, and a sky-high parathyroid hormone trying to compensate. And finally, metabolic acidosis, simply because the failing kidneys can't excrete acid properly. The table here gives you a nice summary of our goals for each one. Okay, and finally, let's talk about the foundation that this entire approach is built on. Because listen, none of these medications we've discussed are going to be nearly as effective without the right lifestyle and dietary changes.
And when it comes to diet, there are two huge things to focus on. First, restricting salt to less than 2 grams of sodium a day is absolutely critical for blood pressure control. Second, for our patients who aren't on dialysis yet, a moderate protein restriction can really help reduce the buildup of uremic toxins and might even slow the disease down.
So to wrap it all up, here it is. Here is your playbook for that patient with albuminuric CKD sitting in your clinic. Get their blood pressure down to target. Start them on an ACE inhibitor or an ARB. Add an SGLT2 inhibitor and counsel them to cut back on salt. These 4 steps, these are your most powerful first move.
You know, when you think about it, with these powerful tools we now have in our arsenal, we're in a better position than we have ever been to manage this disease. It really makes you wonder, are we finally on the verge of changing the entire future for the millions of people living with chronic kidney disease?